My name is Ricky Blusenthal. I'm going to be talking about the implications of Black Lives Matter movement and the social determinants of health for achieving wellness. Let me just start by indicating that I have no conflicts. So let me give you a little bit of background on myself. So at present, I'm a professor in the Department of Preventive Medicine at the Keck School of Medicine at USC, as well as the Associate Dean for Social Justice for our medical school. I'm a sociologist. I've spent most of my career in medical schools, including at UCSF, Charles Drew University, which is in South Los Angeles, and now USC. And for the last 30 years, I've been studying problems of health and epidemiology as it relates to people who inject drugs. So I've had a firsthand view, and sometimes I've been an active participant in trying to deal with both document and then address health problems that are prevalent in this population, and that includes HIV and hepatitis C. It includes conducting research and starting, in fact, the needle exchange program when I was in graduate school. And my research continues to be focused on issues relevant to this population, including the opiate crisis, and then the 4 or 5 emerging epidemics that relate to this population. Just as an overview, what I'm going to talk about is how social determinants of health in general, what those are, talk about how social movements have had a positive public health impact, and then use my own experiences in the social movements related to supporting people who inject drugs as a case example. And then I'll conclude by talking about why I view Black Lives Matter as an important ally and partner in addressing structural public health challenges that disadvantaged groups have. I'd like to start at the end, so let me just share with you what I'm going to basically conclude. So, basically, most of the health problems that we have in our society, are a function of our political, social, and economic arrangements. What I'll show you is that historically, social movements of all kinds have had an important influence on rearranging political, social, and economic order in a way that improves public health, and that the Black Lives Matter movement certainly has those attributes. And I'll review at the end their policy agenda, which really speaks, I think, directly to their capacity to address structural inequalities that account for most of our health problems. All right, so what are social determinants of health? We begin talking about that by noting numerous reviews sponsored by the federal government and others have established these sort of contributions to health, right? So the Department of Health and Human Services maintains that about 20% of your health is a function of your genes or biology, but 10% have to do with the medical care you receive. And then the rest, 70%, are behaviors and environments. A little bit more nuanced views like McGinnis and Brooks make the case that, it's not just behavior environment, but also your social circumstances. And then if you look at the combination of these things, at the end of the day, you end up with a substantial portion, probably 60%, or up to 60% of it, or 70% of it actually being about behavior, social circumstances, and environment. So where do our behaviors, social circumstances, and environment come from? This is a great slide from the Kaiser Family Foundation. Sorry, I'm not sure I had cancer in my head. Anyway, that sort of talks about some of the common social determinants of health. They include things like economic stability, neighborhood and physical environment, education and educational opportunities, access to food, community and social contacts, and healthcare systems. And if we reflect on our own lives, it's easy to see, particularly depending on how you're doing in this in the pandemic. If you like me, and I'll just self-disclose, I'm a tenure professor at a university. I have had to shut down my research, but I've had plenty of other work to do. I have I own a home with my wife and family. I'm pretty secure. I'm still making money. So the pandemic isn't really it's inconvenient. And as a person who cares about other people, I experienced a loss of so many people dying and so many people becoming sick. But in terms of my nuclear family and myself, we've weathered it pretty well. That's not obviously the case for people who are renters. That's not the case for people who are essential workers or low paid essential workers. That's not the case for people who are homeless. And so, it's sort of a strong face validity for the idea that, what's going on in our life in general, economically, socially, has a lot to do with how our health is. Now, social determinants come from sort of the immediate circumstances that we find ourselves in, but they also have historical origins. And so one of the things that's, I think, really important to keep in mind, and I think the Black Lives Matter movement has really brought this to the fore, is that for African Americans, myself included, we come to this society with a wealth of disadvantages that have nothing to do with our individual behaviors, right? They really are dictated by the history of this country. They include, obviously, enslavement, but even following the ending of slavery, police violence, denial of the franchise, Jim Crow in the South, residential segregation and violence in the North, and then they persist. So negative stereotypes and microaggressions, health disparities, mass incarceration, high homicide rates, and then, as obviously the summer and spring showed us, police violence, which represent both existential and emotional challenges to African Americans trying to live and be their best selves in the society. A similar history also exists for American Indian populations and Latinos. And this is, again, another slide developed by a colleague of mine at the Fred Hutchins Center at the University of Washington, which documents what's happened with American Indian and Alaskan Natives over history. And you see the systematic expropriation of land and resources, negative stereotypes, removal of children, destruction of culture, resulting in a circumstance where people find themselves challenged to achieve the good things in life, to achieve well-being and safety. And a similar thing you see with Latinx populations. So, violence, police violence. You have issues of people being prevented from immigrating, which has been highlighted in the last 4 years. Deportation of documented and undocumented people, detaining children at the border, and then health disparities and ongoing police violence. So these sort of systems, these historical systems, have led to contemporary social and economic and political arrangements that expose Latinx population, American Indians, African Americans, and other groups to disadvantages in a profound way. And here are just some common definitions of both structural racism and then also structural violence. And I'll talk a little bit more about structural violence, since it's the kind of institutional arrangements that impact the population that I study most. And includes also racism and sexism, transphobia, etc. All right, so the way we're set up to address these issues can be challenging, particularly from a public health perspective, because when you think about it, most of the problems don't originate within the healthcare system; they happen outside of the healthcare system. They're also related to the distribution of power and policy preferences, and then they're embedded in those same systems of social, economic, and political operations. And so while they reduce the well-being and life opportunities for disadvantaged groups, they also protect and improve the life opportunities for other people. So I don't think the circumstance is necessarily a zero-sum game, but I do think we have to engage with the fact that, and I'll just, again, use myself as an example, I'm complicit in a system that's unequal. And even as an African-American person, I've achieved through luck and hard work some advantages but that makes me complicit in the system. And so I have an obligation to work on dismantling the system so that well-being and opportunity can be more equally distributed in the society. So social movements have been really important in helping us rebalance social, economic, and political arrangements in this country. Obviously, the civil rights movement, by both providing the franchise to African Americans, by outlawing discrimination in public accommodations, by making the federal government a partner in increasing job opportunities and wealth opportunities for African Americans through things like the Small Business Administration program and others, have been important actually in improving African American health over time. So if you have a job, if you are able to vote, you're able to exert influence on the social, economic, and political arrangements in a way that improves your well-being. There are other more recent examples. I don't know the age of the folks on the call, but if you were around in the '80s, the Mothers Against Drunk Driving was a social movement essentially. So largely suburban mothers banded together to address an epidemic of youth drinking and driving, and came up with whole social marketing campaigns, both to change the way parents reacted when their children drank, and then also to change laws. Sierra Club, Green Police are all active, obviously, in working on issues related to climate change. And then, we've had movements in the United States related to alcohol prohibition, and currently now related to the war on drugs that are social movement in nature. The one I'm most familiar with is the efforts related to responding to the HIV/AIDS epidemic. And again, if you weren't around when this happened, I was. It's important to note that the federal government was prepared to literally do nothing. Ronald Reagan didn't even use the term AIDS, I think, until towards the end of his term as president. He was, president from 1981 to 1988. But because of mobilization by sexual minority men and their allies, the National Institutes of Health, other federal agencies were literally remade to sort of respond to this epidemic that was killing so many sexual minority men. It also impacted people who inject drugs, which is the population that I focus my research on. And in the face, the things that we faced back then included homophobia officially. The groups that were being harmed by the epidemic were not seen as politically powerful. There's an interesting analogy of that going on now with the COVID pandemic, and the fact that you really have federal, almost at this point, disinterest in what's happening with the epidemic. Also, a sense that the people who are being harmed, it's their fault, and that the problem is so big and insurmountable. So, a lot of, unfortunate analogies to the current circumstance that we find ourselves in. And then in particular for people who inject drugs, that's what PWID stands for. Both the federal government and local governments were really not prepared to do anything. And so in the face of this challenge, people who inject drugs and their allies began implementing programs to prevent the spread of HIV based on harm reduction principles that included client-directed, non-judgmental, non-punitive, and practical strategies and interventions. And as I'll show you at the end, these same principles actually have influenced the Black Lives Matter movement as well. The kinds of things that you can do to address HIV spread among people who inject drugs, we're calling that there's sort of two primary ways that folks get HIV in this population. So it's through sharing syringes and then through unprotected sex. So in the drug space, there are a lot of different things you can do. So you can prescribe people heroin, you can do medication treatments or withdrawal management, obviously syringe exchange programs, which are now more widespread in the United States. I'll show you some information about that. And you can do a variety of other things to sort of mitigate the harms associated with that. from the perspective of folks. So at the time when sort of community activists, myself included, and others were trying to develop this response, it's important to recognize the federal government was not a partner. So they had prohibited funding for syringe exchange programs repeatedly in the federal budgets. They had propagated in the late 70s drug paraphernalia laws, which we've now mostly unwound. But those laws made syringe possession a chargeable offense. So that contributed to the spread of HIV. Distribution of condoms were banned in some locales. And you even have issues that once you open programs, they can be shut down, which has happened in Orange County and a couple other places in Los Angeles, or I'm sorry, in California, as well as in other areas because they're controversial programs. And then lastly, they're consistently underfunded. So the approach we sort of used to dealing with this topic, this issue, is a combination of activism and research interactions where you're sort of feeding back data about what's happening on the front line, and then feeding that to people who are involved in policy debates, and then using that to sort of push for new regulations or laws that protect the population. So the key ones that have happened in the space for HIV among people who inject drugs include getting rid of the syringe possession laws in most states, getting rid of pharmacy laws or pharmacy regulations that prevented the sale of syringes without a prescription. So we've done that. And then the last big one has to do now with the overdose crisis and making naloxone as readily available as possible. Some of the research I've done has been used to sort of establish that the system that we were in the 90s was harmful to the programs, that the programs actually did work at reducing risk, and that they didn't have an influence on people's trajectory of drug use, so that you could use a program and be as likely to seek treatment as someone who didn't use a program. The other thing is, and I think this is an important theme that I think pops up in the Black Lives Matter movement policy recommendations, is that we have to be more generous to disadvantaged groups. And I won't get into all the details, but essentially, let me just try to explain this to you. So this top one, which is it's not labeled. This is syringe coverage, and that's basically the ratio of the number of clean needles that people have received to the number of injections they would do in a particular period of time. And then these are types of syringe exchange programs. So the ones at the top are the most generous. So they give people, someone comes in and says, I inject 30 times a week. And so someone gives them 30 syringes. And then these ones at the bottom are more limited. And if the goal is that for each injection, someone has a clean syringe, the programs best able to do that are the most generous ones. So that's important. And then when you look at that by risk behaviors, we see an inverse relation. So the folks here have 5 syringes. The 562% have over 5 syringes for every injection, whereas the people down here only have 1 needle for every 10 injections. And then you see the purple or pink and dark blue are risk behaviors, and they go down as you would expect in a linear fashion, the more syringes you have. So the programs don't lead to unintended consequences, and they do reduce risk, and they do that by being more generous to the population. The other thing we documented was that if people were going to get primary health care, they're likely to get it from syringe exchange programs as opposed to other settings. And I don't need to get into this. The take home is just that these were really effective programs. And the truth is they wouldn't be widely available were it not for activists. And then this is lastly some data that I've collected with my colleague, Alex Kroll, who's in San Francisco at RTI International. And what you see here is basically overdoses between 2011 and 13 and 2016 and 17. And in each case, you see big increases in overdoses, big increases in witness overdoses. But in this last one, what you see is that when we began distributing naloxone widely to people who inject drugs, they were using it to reverse overdoses. And so that's what this shows. So 70%, almost 70% of the people in my last study had reversed an overdose using naloxone. And the same thing happened in San Francisco. So when we give people the tools they need to achieve health, they'll use them as we expect. All right. So those are like big wins and over history, over time for this population. But in some ways, we fail to deal with the fundamental issues of social determinants of health. So, implementation and access to these programs is still less than ideal. So again, this is information from Los Angeles and San Francisco among people who inject drugs, and the differences between the blue and orange is between 2011, 13, and 2018. And you see there have been great increases in access to service and overdose training and naloxone distribution, but we're still not at 100%. Access to medication treatment is low. There's no safe consumption sites or safe supply in either location. And then similarly, there's been big growth in the number of syringe exchange programs in the country, particularly in this Midwestern region. There's been a real growth thanks to the opiate crisis. But when you look at it by county, you see it's actually a lot less impressive than the prior map does. And there's also areas that still have great need. So let me just deconstruct this for you. This is data where we interviewed syringe service providers throughout the United States, and then looked at what their reported distribution of naloxone was by overdose deaths in region. And you see there's some regions like the Pacific and West North who are doing pretty well. To a place like the Mid-Atlantic and South Atlantic and the South, East-South are not doing well. And that results in people dying, right? So folks don't have the tools they need to protect themselves. At the same time, this is data again from my studies over time, the social circumstances of my population have gotten much worse. So these are neighborhoods in Los Angeles. And the just take home here is that homelessness increased in this population dramatically. And that has big time consequences. People who are unhoused find themselves having to move frequently. And oftentimes they're being moved because of the government or security guards. This results in people losing belongings, identification, medications, access to food. It disrupts their social connections, and then they have more difficulty maintaining adequate hygiene. And it also makes you feel bad. Like, I don't know when the last time you moved was, but moving is very disruptive. And so if you've got people moving 3 and 4 times a month because they're unhoused, that's going to make it harder for them to do better. And then, of course, they're exposed to violence at a high level, theft, mental health problems are substantial, food insecurity is enormous, and poverty is widespread. All right, so what does the Black Lives Matter movement have to do with this? Well, and I recommend you go to M for BL, so Movement for Black Lives. This is basically a website where 170 different Black organizations came together to create a consensus document about a policy agenda to move forward. And I think this is from the preamble, and I love this statement because I think one of the things that I've come to understand in my research and observing these things over time is part of the problem with our policy debates about issues that are controversial, like police violence, like HIV among people who inject drugs, is that we don't want to put at the center of our conversations the people who are being harmed by the policies. So this statement, there can be no liberation for all Black people if we do not center and fight for members of our communities who are living at the intersections of multiple and mutually reinforcing structures of oppression. And that's really that's one easy way to think about the difficulty we have in achieving wellness in our society for disadvantaged groups, is that we're often not willing to talk about what are the things that are actually harming them, and then how do we change the policies related to that. So, whenever there's police violence, for instance, there's lots of conversation about what the police do, but basically the justification comes, and certainly from the perspective of many prosecutors, is like, is there some explanation that makes their behavior reasonable? Well, if you flip that and say, hey, someone just got killed, there's no good excuse for that. So if someone dies, you should have a higher evidentiary standard, not like, oh, a reasonable person might have done the same thing. That's nonsensical, and that's because you're not putting the victim at the center of it. And that's right, you know, it's also racial, right? So, you know, when white folks are killed, there's often, you know, a much different view towards the impact on the victim than it is for African Americans. So their demands are widespread, end war on Black youths, Black communities, Black women, so on and so forth. I'm going to just talk about the war on drugs because that sort of overlaps with the research and my own activism, which has really been in that space. And so what they're calling for is decriminalization of substance use, removal of barriers to immigration that are related to substance use and sex work, reparations to the families and people who've been harmed by the war on drugs, and then investment in comprehensive, accessible harm reduction services. And there are other things, but this is just sort of a summary for our purposes here. And you know, if you think about the social determinants of health, this agenda is incredibly responsive to that. So if we weren't arresting lots of people for their substance use, we reduced incarceration, you would naturally have improvements in educational and employment outcomes, more family stability. And because in this country, employment is often related to healthcare, you'd end up with a better healthcare utilization in these populations. Similarly, reparations, and this gets back to the point I said at the beginning, which is great harm has been done to communities, individuals, and families as a consequence of this war on drugs. And we do need to have a conversation about what is it that we should be doing to make up for the in many cases, intergenerational harm that's been done to these communities. And there are lots of ways to do that, or that you don't have to necessarily call it reparations, but there are lots of ways to sort of address that historic harm that would result in better life opportunities for minoritized populations. They also are calling for comprehensive implementation of harm reduction. So in Los Angeles, we see this. We've had our Black Lives Matter movement has had a lot of success here. So in the last couple of years, they've won civilian oversight of the sheriff's department. They've won approval by the Board of Supervisors to not build another jail, and instead to begin moving those resources into community-based services that would deal with the folks who have substance use problems, people with mental illness and severe mental illness, and sort of really creating a social infrastructure that would include harm reduction to take care of people in ways that don't involve incarceration and police, which are very dangerous to them. And then finally, I think there are this investment in social infrastructure and community building can make a lot of sense for these populations. One of the things that happens, obviously, is that if you've had experiences being incarcerated, experiences in substance use, you're not going to have a resume that makes it easy for you to get a job. And even if we get rid of the box that says you have to report that you've been a felon, the truth is you can't hide holes in your resume, right? So any person with a look of critical thought, will identify, well, for 10 years, what were you doing, right? Or for 5 years, what were you up to? But those experiences well prepare folks to provide services to people who are still struggling with these issues. And I think one of the things we've seen in Los Angeles that's been tremendous is that with the amount of money that's been directed into homeless services, there's been a real emphasis on hiring people with lived experience. And so that's another way to give back. So it's a way of sort of dealing with the harm that's been done, and you do it in a way that's going to actually make you more effective. So you're hiring people with lived experience. They're going to be close to the problem, more apt to come up with solutions that work, more motivated to do the work, less put off by the frustrations that might come with it. And you're helping them rebuild their lives. All right, so just to conclude, critical public health goals relating to the sort of health problems that I look at my work are likely not to be achieved without the sort of remaking of the social institutions, in this case around the war on drugs. And I think the Black Lives Matter movement really incorporates that understanding. So I think that at the end of the day, they're an important partner in creating a society where we can improve public health and promote wellness. And then I would lastly just end by encouraging you to work locally and nationally in collaboration with them, with the idea of both dealing with improving health outcomes for Black folks and other minoritized populations, unwinding our criminal justice approach to mental illness and substance use, and supporting harm reduction strategies. So that's it. Thank you very much for your attention. I'll stop sharing now. Actually, let me just do my acknowledgements, and then I'll stop sharing. And then if you'd like, you can put questions in the question and action box or in the chat box. So there's one question, which is, what would be more acceptable term, Black American or African American? Well, as you can tell from my talk, I'm all over the map. So I think my preference is African American, but or I know my preference is African American, but I don't think that's the best choice. I think it's sort of whatever people feel most comfortable with. So in my talk, I said I used the term Black. I don't think I actually use Black American, but I don't have a problem with that. Stephanie asked, Oregon just decriminalized drugs. How long before you think we'll see improvement in their lives? That's a great question. So I presume lives, you mean the people who use drugs. So let me start with a few caveats. So the first, while many people will not get arrested for having substances, people will still get arrested for things like being homeless, or things like, or unhoused, or being proud, being poor. So perhaps if they're engaged in petty crimes, which is common in this population. So there will be a decline in arrest, I think, pretty quickly, but it might not be as much as you think because of the broader infrastructure around how we treat people with substance use disorder. So that's why I think, and that's why I really appreciate what the Movement for Black Lives is doing. I mean, their policy recommendations are really, really thoughtful. And you have to sort of go further than just decriminalizing. You do have to really go into, okay, now what are we going to do to keep this population as healthy as it can be? So syringe service programs, naloxone distribution, easier access to medication treatment, housing, right? There's still a lot of stuff that you have to repair. So I think in the short term, there'll be less arrest. In terms of people's actual well-being, it will probably take a lot longer for those kinds of results to be detectable, and they will probably actually require additional work. So if you just did decriminalization, you're dealing with a problem that's faced by this population, but not the only one. And so you really do have to go through the whole list to get to a place where you could really begin to see the kinds of health outcomes we'd hope for. Oh yeah, and so Sylvia asked, are the Black Lives Matter recommendations applicable to other groups? And 100%. I mean, I've taken to saying in my own work that given the amount of stigma associated with people with substance use disorder, they're a minoritized population, just like African Americans are, just like American Indians are, just like Latinx people are, just like sexual minority people, trans folks. So yeah, I think they're not just about Black folks. I think they're applicable. The recommendations would be helpful for all groups. All right, then there's a question, what's a book that you would recommend after the new Jim Crow? That's a good question. I gotta say, I haven't been reading a lot of books lately. I will tell you the last book I read, which I really liked, and it's related to the new Jim Crow, but it's more about racism. So I'd recommend reading Dorothy Roberts' book, Fatal Invention, which is about how race has been misused in biomedical research. I work in a medical school after all. But it covers, it certainly encapsulates the findings of Michelle Alexander's work, and then talks about, I think in a very meaningful way, how the politics of race end up creating harms to African-American folks. And that also includes the stuff related to criminal justice. So I'd recommend that. All right, are they working in enough childhood factors? Yeah, I think so. I mean, I do, one of the things that's not well documented in drug use studies, epidemiological studies, is the impact of both having children being separated from parents because of substance use disorder, or for parents who've had their kids taken from them. So I do think a lot of the recommendations have implications for that, and I know explicitly in some of the other war on things include war on Black parents. So yeah, if you go to that website, you'll see there. I think there are. I should have counted. There are a lot. There are like 15 or 16 different sets of recommendations that are all pretty thoughtful, and I think they cover that stuff. All right, how do we deal with long-term impacts of incarceration? I think, I do think we are going to have to start moving towards a reparations type framework, uh, mostly because, and I'll just use stuff that I know well. So I've been collecting data in East Los Angeles among Latino former gang members since 2001. And these men and women end up spending, most of their formative years in jail. When they're in jail, they don't have access to health care. They don't have access to good health care. Their education basically stops. I mean, I've had people in my study sign their name because they've been in jail since they were 11. So the kinds of help that those folks are going to need to get back on their feet and rebuild their families and their capacity to take care of themselves are substantial. And, I think the worst thing that we could do is pretend like it won't require an enormous investment. And some of it is creating these jobs where they serve other people, changing, getting rid of the checkbox. Some of it is getting rid of things like cash bail. But I think the other is that they're going to require extensive case management. And it's no different than the sort of work, at least in Los Angeles, that we're doing with homeless populations. It takes a lot of work once someone's life has sort of come apart to the point where they're unhoused routinely, to help to get them back into a space where they can be housed again. Case management, a lot of access to resources, healthcare, and other things that sort of rebuild their trust in others, and then help them deal with the immediate problems that they have. And then all of that work should be, driven, as we do in sort of harm reduction, by what they see as our priorities. I mean, one of the things that's been a great frustration, at least in my research career, is that when we have policy debates about how do we help populations of people who inject drugs, the preferences of people who don't use drugs are often seen as more important than the preferences of the people that do. And the truth is, even if you have severe mental illness, even if you have long-term chronic opiate use, you're capable of making decisions in your life, and people should support you in doing that. And that's the quickest way to get to better solutions. All right, so last one. I like when you said that we can do reparations without calling it that. Yeah. But yeah, and I do. And so the question was, but we still need to build support for minorities and to rebuild better lives. And that's 100% the case. And I think that's a political case that we have to make. And I'll just, again, make some points. Some of the stuff has changed recently because tax law changed. But, just keep in mind that up until the last Trump tax cut, really the largest housing program in the United States was the tax deduction people like me receive from interest on our home mortgage, right? So what we have to acknowledge is, and that's why I brought up this idea of complicity. Look, I was the joke was I was born a poor Black child, and I'm not now, but I am where I am not because I'm a genius. It's because I've worked hard and I've been lucky. And the truth is, there are lots of supports in the system to continue supporting me being lucky. provided you to work hard. That's not the case that the folks in my study experience. So they don't get returns on their hard work. They're more likely to get incarcerated. There's a ton of, particularly for unhoused populations, a ton of aggression directed towards them, both by police, sanitation worker, and their neighbors. At the end of the day, for these groups, we're doing everything in our power to make their lives awful. And so, I do think 100%, we need a new politics that leans into helping people with problems and understands that their problems do not arise from their individual choices alone, but are the function both of what's happening in society now, what's happened in society before, and that we all owe them um, uh, uh, resources that are going to give them a chance to have the best lives they can. So thank you for that question, Sylvia. So we still have more time. Other questions? Oh, okay. Oh, it's David. Hi, David. Let's see here. Great points, especially on the impact of legal consequences of drug use and families across generations. Investing in people and their abilities and effective community sounds important. Where should we direct resources? School, business, health, built environment, etc. I think we have to do all of them. I really like the question. Let's see here, who was that by? By Stephanie, about Oregon's case and their decriminalization. I mean, I think what we're going to learn in that circumstance is decriminalization is good, but not enough. That's the case with most things, right? I mean, even in the harm reduction world, I've lived and been involved in, making syringe service programs more widely available and making sure that they have the best model of care that they can have. But that's not enough, right? You've got to do other things. So I think we do need direct resources at schools, at businesses, at the healthcare system, at the built environment, and et cetera, to be ultimately successful. Now, we don't have to do all of it at once, because of course that seems like a heavy lift, but we should, we definitely need to change the paradigm, which is when we think about what's happening with low-income people or disadvantaged people, we often don't want to put resources into them, and the truth is we can't. We do, and the truth is, I'm sorry, I keep saying the truth is, but we should put resources into them, and those resources are no different than like the resources I put into my own children, or the resources that upper middle class people put into their kids. So it's just that they're not capable of devoting tens of thousands of dollars to their kids' education. So, and just to make that even a finer point, the typical private school in Los Angeles County costs something between $20,000 and $40,000 a year. The typical student, LAUSD receives for the typical student in their system, $8,000, right? So yeah, you get better outcomes when you spend more money. So I think, we should be redirecting enormous sums of money into schools so that they have smaller class sizes, into teachers so that they have the best training and resources to enrich the lives of these youth, so they will have better lives in the long run. And them having better lives mean they'll have better jobs, they'll make more money, and we'll all benefit. All right, and then there's the last one. Ask health practitioners, how can we do our part on the ground? Well, there's a lot of great ideas about that. In my position as a social justice associate dean, we're really focused on up with trainings for practitioners in areas like cultural humility, trauma-informed care, and then structural competencies, so that frontline practitioners know enough about the patients in front of them that they be creative and advocate for other services that are going to be helpful for their outcome. So, and a typical example is, circumstances where people are late for appointments or appointments, and they sort of are thought of as bad patients. And in my mind, it's like, no, they're not bad patients. We have a healthcare system that's not very patient friendly, unless you have a salary job and access to transportation and no childcare or elder care responsibilities, right? And so if you're low income in that system, you're going to have worse outcomes because you have all of those things. You have barriers to transportation. If you don't work, you don't get paid. And so I think we have to begin, particularly health practitioners, as acting like they know that about their patients, and then creating systems like being open after 6, or even going into people's homes to provide health care. We're fortunate at USC, we have this fantastic street medicine team. And they've done great work in terms of providing indicated primary care services to unhoused people in Los Angeles. And there are other similar programs. UCLA has some, and then hopefully, we'll move towards a paradigm that recognizes that, yeah, for a certain portion of us, getting healthcare isn't challenging, but for most of us, it is. And we should redesign our healthcare system to reflect that. All right. Well, thank you so much for joining us. I appreciated the opportunity to speak with you. If you want to reach me, feel free to email me. My email address is rbluethen@usc.edu, or you can just look up Bluethenthal, Ricky Bluethenthal. I'm the only Ricky Bluethenthal on the planet, so I am relatively easy to find. Thanks again, and I hope you enjoy the rest of the conference, and have a great weekend. Bye-bye.